Well, good afternoon, everyone, and thank you for joining us today. My name is Anton Gunn, and I'm an advisor to the Intersection, a Robert Wood Johnson Foundation initiative focused on leaders in advocacy and healthcare. And I want to extend a warm welcome to everyone who's joining us today. See, the Intersection is a place to convene, to learn, to share resources, and to discuss what individuals and organizations are doing to build anti-racist health systems. You can check us out at meetattheintersection.org to access a wide range of helpful resources, including direct access to our podcast on all streaming platforms. And if you're not following the Intersection's LinkedIn page, you need to do so now. You can connect with others, stay up to date about future events and resources. And we'll also have time today to take questions from the audience, live questions. So if you have questions, please add them to the chat throughout today's conversation. Now, speaking of today's conversation, we're bringing together leaders from community-based organizations and healthcare organizations who are reimagining how care can be delivered in ways that are more responsive, equitable, and rooted in partnership. Midwifery and birthing centers are on the front lines of this kind of change. It's giving patients more options, centering dignity and respect, and offering a community-centered approach to care. And so we want to think outside the box a little bit, how we can take these lessons from the reproductive justice community and think creatively about taking a community-first approach to other areas of care. So today, we are joined by a dynamic group of leaders who are disrupting the status quo by addressing the social and structural barriers through advocacy, midwifery, and the implementation of flexible care options led by communities that they serve. So first up on our panel today is Janice Fountain. She's the executive director of Yellowhammer, an abortion advocacy and reproductive justice organization serving Alabama, Mississippi, and the Deep South. She is also the founder of Margins, Women Helping Black Women, a local community aid organization that addresses reproductive, financial, and material need of low-income Black mothers and their children. So welcome her. Jenny Joseph is a British-trained midwife and founder and president of Common Sense Childbirth, which operates a national training institute, healthcare clinics, perinatal task force, and birthing center in Orlando, Florida. It is also the first and only Black-owned, nationally accredited private midwifery school in the United States. She was recognized as Time Magazine's Woman of the Year in 2022 for her work promoting perinatal equity. Our third panelist to join us today is Dr. Sonia Shin. She is an associate professor at Harvard Medical School and an associate physician at the Division of Global Health Equity at Brigham and Women's Hospital in Boston. Her work focuses on advancing health equity through community health workers and other community-based interventions. She provides clinical care to patients living on the Navajo Nation Reservation in Gallup, New Mexico. Thank you all for meeting us today at the Intersection. Now I want to start with you, Jenny. As someone who's fighting to improve access to midwives in the United States, can you help us level set a bit by giving us a quick history on the current state of midwifery in this country?
Yes, well, we're in a unique position in the United States because we still have not accepted, integrated, acknowledged midwifery as an essential public health service. Around the rest of the entire world, midwives are normal. Midwives take care of all women and birthing people who are fitting into a healthy and normal pregnancy, birth, postpartum, and interconceptional period. OBs handle the complications, and that's where the difference is in the US. We have it completely upside down. OBs who are highly trained, who are surgeons, who have all of these skills for crisis complications and high acuity patients are taking care of normal. And in that upside downness has caused so much problem for the birthing population in the US. And we never had these problems, these iatrogenic concerns before because midwifery was how we got here.
Mm.
Midwives delivered America. Midwives always have been part of communities for millennia. And at this point, I think we really need to look, and I'm so grateful to be here today to join this conversation.
Yeah, thank you for sharing that. I mean, you made me reflect back on, my parents and grandparents' generation. Everybody was delivered by a midwife
Mhm.
today, but now we've taken a completely different approach or changed the approach, if you will.
Mhm.
But that's why we're here to talk. So I
Yes.
got a question for you, Janice, because you're on the front lines advocating for reproductive rights and abortion access in Alabama. Okay. So what does reproductives teach us about how social policy and community-based care can drive health outcomes?
I think one of the things for me to be really unapologetically about naming is that some of these things that we see as like misconceptions are actually deeply intentional harms in my
Mm,
state. So when the state implemented an abortion ban, it then implemented regulations on midwifery care and then on birthing centers, and then proceeded to close the safest OB units for Black women. So when I
mm,
think about all of the fights that the state has had to fight, whether it's Dr. Skanes fighting the Alabama Department of Public Health so that she could function at her birth center, or if it was Yellowhammer Fund fighting the state to get people out of state for care, the common thread there is criminalization. And so just
mm,
looking at this from a broad, expansive lens of if this is an intentional thing, an
mm,
intentional harm, how do we address this violence in a way that really acknowledges that it's violence, right? And not gifted ignorance in such a way that we have the same conversations with the same people that are intentionally inflicting harm.
mm. Wow. Well, I definitely want to come back and double click on some of the things you shared there, but I want to go to you, Sonia, right quick, because you work closely with the Navajo Nation community in New Mexico. What are some of the key approaches or care models you've implemented to improve health outcomes, and how were they shaped by the community?
Yeah, thanks, Anton. I'm really excited to be here at this intersection. So first of all, like for those who aren't really familiar with indigenous or rural settings, Navajo Nation is just very, very vast and rural. So just for context, people might have to travel 2 or 3 hours just to make it to their appointment. And, if they have to travel 2 or 3 hours to their appointment, that also means, if you think about it, to buy their groceries and sometimes even to buy like drinking water. Okay. So, from the healthcare system, I think, I've really been interested in this question about like, how do we design a healthcare system that shifts the burden of responsibility from the patient to the system itself, because we often think like these patients are responsible for making it to their appointment, or if you tell a postpartum woman that she has to lose weight, if she's only coming in to buy groceries maybe 2 times a month, like what would that feel like?
Hmm.
So part of the work that we've done has been to build out community health worker programs and really think of healthcare as a continuum that really starts in the community. And the other piece that we've been working on more recently has been related to food as medicine. So thinking about, what does access to healthy food look like? And I think your question about involving, community members from the start is really important because, for all of these programs, we've had to really be thoughtful, and especially myself as, kind of an outside visitor to this community, to take the time to listen to our partners. And, just as an example, when we were starting to think about access in 2012, our community partners were like, you know what we don't want is a program that gives people vouchers to go to those big box stores, that are on the, kind of border towns, because that's not actually helping us as communities to develop. So whatever you do, you have to think about how do you actually strengthen the local food systems in that process. And so, we've tried to do our best working with small stores and helping them with produce supply chain, so that they can redeem the vouchers for produce, or for our more recent medically tailored meal program, we've worked with local, Navajo growers and ranchers to source the foods. So it's kind of just one example of how we've really tried to be accountable to our community partners.
Well, very good. Thank you for that context, and we can talk a little bit more about those partners, the type of partners that people should be looking for in their community. But I want to go again back to Janice. You talked about intentional harm from a policy standpoint.
Mhm.
In a place where people may be experiencing similar things. What on a local level can be done to, save lives and improve health outcomes? Talk to me about like alternative pathways that may not involve their closest local hospital. Give me some sense of what might be able to be done.
And so I actually just had this conversation yesterday with Dr. Teresa de Paredes about just how common it is for communities to hold so much of the necessary work in other places outside of the US. For me and the fund is really important for us to be in deep relationship with community and not just like really extractional, not,
Mhm.
transactional, but really be in deep partnership in a community. And one of the things we like to affirm is that this work has already existed, right? So we're not creating something new, but we're rather going back to it. And
Mm,
there's a bit of stigmatization now for like out of hospital care. So how do we have those conversations with community members that have the interest, that have those skills, but that have been told to like that's not real, that's not safe. A lot of the conversations we have with people, they're naming their reliance on hospitals because it's safer. And then, but also deeply scared of the dynamic of like not making it out. A lot of our work has been building something new. So with naming the harm and naming it being intentional, it really makes our responsibility to build a different way of engaging. And I will say for Alabama Birth Equity Initiative, that's exactly what the point is, right? We have physicians that are midwives, that are NARM certified preceptors. We have community organizers, activists. We have lactation specialists that are all coming together and saying, hey, community needs more midwives. We need a solution. It's not going to be the institution. How do we get there? How do we also let community know what the state is doing in terms of harms? Alabama is one of the only states where the midwives can't do the newborn screenings. And we think there the intention is safety, but it's not. The intention is to keep us under mandatory reporters and that criminalization isn't beneficial to anyone. So a lot of acknowledging that it's intentional is so that we have the deep responsibility of doing something differently and building that out.
wow. Thank you for sharing. Jenny, I saw you nodding
Mm,
your head to some of that. Can you just
all
talk
of it.
about, just please go ahead, feel free to share.
Yeah, look, it's like, I mean, I got off a plane in 1989. I've been here a long time. And it's really interesting because there is so much brilliance throughout the United States in all of our various jurisdictions, regions, etc. We all of us understand the problem. We all of us know the solution to the problem. We all of us keep wringing our hands and talking about the solutions to the problem. But yet, it's just it really it's just on my heart right now that we could just get into action if we would just adopt the things that we are clear are missing and are necessary, right? So midwifery is an example of standardized ways of being as far as how the providers take care of not only the birthing person and but the babies, the siblings, the partners, and into the community, elders as well as, you know, incoming. The midwives center those folk that they're taking care of as a matter of course. That is what they are called to do. And their scope allows them to continue to do that until there's a problem. That is a universal historical way of being. That's an ancestral way of being. That's an indigenous way of being. Like, you can't make it up. It's already so, right? And so when you think about how we have worked so very hard to dismantle that as a system of healthcare delivery, because we recognized and we pushed out well, we can't do the spiritual stuff. Oh no. We can't do the social support stuff. Oh no, we can't do, we can't do, we can't do. And what we've got left is literally what we're seeing here in these United States. The disparities are a direct result of not having a patient-centered, person-centered model of healthcare in the USA.
Jenny, if I
Mm,
could follow up with that, oh my God, I'm,
go ahead.
I'm deeply moved by Jenny all the time, and I was going to keep my fangirling to a minimum, but I'm struggling today. I appreciate that because I had this conversation with Kiana Lewis, who's a midwife in Texas, about how our grandmothers caught babies in conditions that were hard to survive. So less of the like, this is this fun thing that we're doing as a project, and more of like, this is survival. It's not magical, but it's from an intense sense to be responsible for the folks around you. And for Alabama Birth Equity Initiative, creating more midwives doesn't just mean the folks that have historically had access to schooling. It doesn't just mean people who have extra time, but how do we go back into community and say, your community deserves advocates that are close to you, that are nearby, that you already trust, and they deserve to have access to those skills and learning and making sure that not only we say that, but we affirm that. So we compensate you to go back to school, but we pay if, if your rent isn't paid, you're not going to focus in a school setting. So just being intentional about that, because when we talk about legality, we might not always have legality, right? Like, and there are people inside of institutions that are going to choose their licensure. But what I know of community is that community is not going to let the person next to them suffer. Miss Susan that you know on the corner that sells ice cream that knows what you need is not going to say, well, I'm going to watch you become septic because there's a law. So just really leaning into what's innate to us. I think the mandate to do this work is deeply ancestral.
Yeah, so that's an incredible point, an incredible perspective. Sonia, I want to bring you into this conversation. Just I want to hear from a healthcare side of the things. How can healthcare organizations shift the power and ultimately the decision making to include people who are most affected? Again, we know what we are and we know what we've gotten away from, but what can, from a system or organizational standpoint, get us back to the people who are most affected, and then ultimately improving health outcomes. I'd love to hear your thoughts on that.
Yeah, I mean, I'm just listening to Jenny and Janice, and I think, as somebody who works within a healthcare system, even from my perch, we know that our system is broken and that we really have like just eroded any trust that we might have had in the first place. And so, patients are like, there's just many, many reasons why a patient would be reluctant to come in for care, And so the fact that we have people who belong to the community, community health workers, midwives, they're like, I'll give you an example. Like I have patients that I've seen, and it took them 2 or 3 years to even come into the clinic. But what was
Mm,
happening is our community health workers were going out there and visiting them, whether it was in their home or under the bridge, you know, building that trust. And then, maybe I was going out there and doing home visits as well. But our whole system is kind of predicated on this model of like, no, 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 it's the patient who comes to us, So just having a little bit of humility and maybe like unlearning some of the stuff that we've been like taught in medical school and realizing that like, trust is something that we have to earn. And we also have to trust our patients, like if my patient's not making, sort of like what I would consider the best decision, we have to understand that like, each person, each patient is making the best decision for her in that particular moment of her day-to-day life. And so it might be on me to understand, kind of what that context is. So from a system standpoint, I think there's some promise to having patient and family advisory committees or sometimes community health boards, but there has to be like real governance in place, to make sure that the healthcare systems are accountable to that community input.
yeah. Jenny, I want to bring you back into this because some of the people we may have who are watching today and learning from us today might be in those systems, and they do understand that reproductive care can happen outside of the healthcare settings, so to speak. But could you share a little context of what makes these models outside of the system more responsive to what patients need and what would be most valuable for them? And how do we normalize that responsiveness across the board? I'd love to get your insight on that.
Yeah, I think obviously when you're smaller, you don't have those bureaucratic hurdles that
Mhm.
unfortunately are part of the American structure, right? So we work in community space from a perspective of building out the perinatal ecosystem and the infrastructure for that system. What we don't have, and what we may one day hope and dream for, is the collaboration with us, being left alone to do what we do, how we do it,
Mm,
because in that space, we have an ability to engender trust and belief, understanding, as well as to be able to continue to hold the respect and dignity that every patient needs. So, what we don't have is an ability, and I think it will come, but I'm not, like I say, it's not there right now,
Hmm.
where the institution and the providers understand that we are on the same exact team, the public health, the researchers, rather than, like Janice says, extract out of the community space, we need the collaboration. We need to be colleagues. We need the navigation. We need really the same thing the patients need, that the people need.
Mm.
We need respect and dignity to be maintained while we build our relationships of trust. Because once
Hmm.
we trust each other, the community is fine.
Yeah.
And they will see that, they will feel that.
Hmm.
These are things that are embodied, and that's why these determinants of health play out because they're not really, these root causes are not physiological.
Hmm.
These root causes are historical, they are
Yeah.
structural, they are deeply embedded, and they're perpetuated, they're condoned, right? There isn't anybody saying, no, this can't be when we're changing these social determinants of health right now. That's not what's happening. That has never happened that way, right? So if we take on the holistic approach to, changing and righting the wrongs that we are experiencing, everybody wins. The providers, the institutions, the risk managers, everybody calms down and feels better. Right now, the level of burnout, moral injury,
Hmm.
pain,
Hmm.
trying to hold this thing together. I
Hmm.
mean, that's why people are flocking to places like the intersection to just take a breath a minute, like calm
Yeah.
down and settle because, we are okay. There's some others like us. It's not me on my own fighting this good fight out here. So both of these things have to happen simultaneously. But someone has to make the first move.
Yeah. Yeah, that's good. That's so good. So good. I mean, like, the point around burnout, people, do show up to the intersection to, rest and reconnect, and, just try to find their way through it. And we definitely understand that. Janice, I want to come to you because you are actually in a part of the country that faces significant disparities and inequities. And I wanted to see if you had any examples or something that you could share would be beneficial to our audience on how thinking creatively to put people at the center of the care can help level the playing field in practice. Give me some sense of where that might be an opportunity.
I will name that the lack thereof has serious implications, right? We did a 48 county bus tour through rural Alabama, very
Mm,
much in parts where people said that's not necessary, they won't have valuable insight, they're going to
mm,
run you out of there because you advocate for abortion. And that deeply was not my
wow.
experience. The people that we talked to were happy to just feel heard, that we even cared what they had to say. And it's not every day. I know, Anton, I know you've done that work of right knocking on doors and talking to people. I wish
Hmm.
that was a more common practice of just hearing people, meeting them where they are in a literal sense, instead of just saying that catchphrase of we're meeting people where they are, and then you just put the mic down and you don't do that
Right.
work. We talked to people that said, hey, my daughter isn't being allowed to get a pap smear until she's 25.
Wow.
And we were like, wait, that's not a law, that's not a regulation. Like, and we wouldn't have known that had we assumed that the studies that were done or that the information we already had, if we would keep assuming that we're experts of people lived experiences, we can't create something that actually serves them. I think broadly that's an issue, right? We
Mm,
have varying levels of maternal health expertise, reproductive health expertise, and otherwise, and we engage people in such a way that it's not a dialogue. It's very much a
mm,
lecture, and we don't hear them to inform how we do our work. Being in the coalition and having Dr. Heather Skanes and Dr. Yashika Robinson be present and just name the institutional harms, but also name that you have to be deeply critical of the environment in which you're educated, right? Like James Baldwin told us, I feel like that was very much correct because we have to
mm,
assume that any institution born out of a white supremacist country is going to be colonized to some way, and we have to engage and interrogate it. And that's why I appreciate Sonia's mention of just like the onus being on the physicians, it being on us that are seeking to do the work and not the people we're doing the work for. I will say people are very misinformed about the possibilities about Alabama Yellowhammer funds to the Attorney General to get back to our work, and we won. We had a policy win of just affirming Alabama birth equities work in the state. That was HJR 57, and that passed as well. So just being very loud and vocal about what happens when we fight back.
That's
We
good.
had 20 people sign up to become midwives for the first
Wow.
section, and we just had that interest meeting in January, launched the coalition in December. So it's just telling us that this is something community wants.
Great.
The model was one that people responded to, and they're actually quite shocked. They're like, "Oh, this program is for us. It's not something that you feel like you're putting on us, but this is something you thought about that was for us to be able to engage." So just being, I think when you're intentional with the programming and you're in deep relationship with the people you seek to serve, the work looks different and it's more impactful.
Wow. So I got something for you, Jenny, and I got something for you, Sonia. But before I do that, to everybody watching, if you have questions for our panelists, please drop those questions into the chat now. We're going to come back to them in a couple minutes to be able to get to some real live audience questions. And so if you got them in the chat, please drop them in for us. So Sonia, I want to talk. See, you are what I would call at the intersection. We're at the intersection today, but you are also at the intersection. Okay. And so the context of your work of clinical care and community-led health models, I want to ask really, what's been the most effective in your experience in shifting institutional practices to better align and match with community priorities? What have you seen has been effective in getting those things to be better aligned that leads to better outcomes?
Yeah, thanks. I was actually reflecting on, the fact that this show is called The Intersection, and I
Mhm.
appreciate that. I feel like I've always like just personally always been sort of like an outsider, insider type of
Hmm.
person. And even though these like kind of intersecting spaces are sometimes like the weakest points, like they're the failure points, like when like just as an example, when a woman transitions from like, obstetric care into primary care or back, those are drop points, but they're also, the kind of like open spaces for creativity, So I think that like building that connective tissue has been, really what I've been interested in. Um, my work has really focused on building the evidence base, like trying to be kind of like, the greasy overall implementer, but like, working with communities, getting the guidance from them, building, these programs that actually fly because they're designed in the real world with our partners that are really going to like be able to take this up, beyond, and generating the evidence base.
Hmm.
I will say that's not enough. Like
Hmm.
sometimes you can build the evidence base and it's not enough to shift policy. So I think,
Yeah.
increasingly finding ways to, for us, for instance, on Navajo Nation, those healthcare providers, that Jenny mentioned are sometimes morally burned out. They
Hmm.
feel very disempowered too when they
Yeah.
see, their patient bounce back into the hospital. And so being able to offer food as medicine has been like really meaningful to them. And then
Yeah.
they've become the folks both at the local level and even the national level at IHS that have been very interested in, building long-term programs. So I do have hope, but I sometimes get a little frustrated because that institutionalization is like really slow.
Yeah. Yeah. Change moves slowly. I'm gonna come back as we close to ask some questions about that to the three of you. Again, if you have questions, drop them in the chat. Jenny, I want to go back to something Janice said about the people signing up to wanting to be midwives, right? So,
Mm.
what lessons from your work training and mentoring midwives, especially as it relates to diversifying the workforce, are critical for mainstream health systems seeking to center this level of autonomy and knowledge and care? What would you say are some lessons from your work training that would be helpful for people in mainstream systems?
One of the things is that we really had to focus on was the justice side of things, right?
Oh,
It
mm,
was so important not just to put a midwifery curriculum down and say, let's go, but rather embed and, throughout the curriculum, draw the parallels and the relationships, how we got here. So
mm,
obviously starting on the history, Black midwives, enslaved midwives, the African midwives already came. They were skilled, highly skilled, obviously, right? And they were dependent on to get this, the human commodity of, human chattel. They were the guardians of that. They kept people alive. They got people through. And so that was a legacy on which the so-called granny midwives managed to work through Jim Crow, right?
Mm,
They had those skills passed on to them down those
mm,
lines, mother to
mm,
daughter and aunt to
mm,
niece. And
mm,
they continued that up into the mid 20th century before they were eradicated on purpose. So policy began in 1920 to start that process, eradication of that traditional knowledge. So we're building our midwifery training. We're doing it to make it match where state by state there are different rules and laws, but the general, consensus of how a midwife who is a community midwife is operating is hobbled in the USA by that person not being able to have access to the hospital system when
mm.
they go outside of their scope. So it's
Yeah.
not that midwives don't want to bring people in or move to the next level when necessary. It's that they are literally practically banished, right? So
Wow.
we teach from a perspective of two angles. One, the justice, the history, and the importance of learning skills in that apprentice model, in that one-on-one preceptor to student model, but two, to navigate what's so. The reality. I have a hashtag. It's time to tell the truth, right? It is no point us blowing smoke and training them to do all these things as if something's magically going to be opening up when they're finished. No. So
Mm,
it is like guerrilla warfare almost in terms of trying to educate so that when they get out the gate, they're safe, they're feeling supported, they are able to be fully in their power to the top of their credential.
mm,
And
mm,
that I think needs to be applied in medical schools, the same approach in any ways that we bring our healthcare providers to their certification. We have to interweave structural, historical, all of the harms that are already here aren't going anywhere anytime soon so that they can prevail. Otherwise, we see this horrible attrition after all this work, all of this investment. People say, I can't do it. Then they run away.
wow. Wow. You said a lot there that give me a lot to chew on, and I know it's giving all of us a lot to chew on.
Mm.
Janice, I wanna start with you with this last question at this point. We're going to get more questions from the audience, so if you have them, please drop them in the chat. But I want to ask, like, in a space and place where change and systemic reform moves slowly, how do you sustain hope and momentum in that kind of environment?
I think that's a really good question because I often say I'm in the work because of spite in some ways.
Hmm.
I do deeply, again, feel that this mandate over what I do with my life is ancestral. I didn't like come into it and choose it. I didn't think that it looked fun. I actually came into this work as a deeply impacted single mom
Hmm.
that needed abortion access, that needed assistance from the state, both of which were deeply hard for me to access. I think maintaining hope now is just really, it's more of a deep responsibility. Like I have hope because I'm in community and we're all engaged in really meaningful work. I have hope because I get to learn from people like Jenny Joseph, like Dr. Shin, like Anton, right? But more than that, like this is work that has to happen. Like there's no, like the when is now, there's no more if. So it's
Hmm.
really a deep responsibility to my community, to my people to move work in this time. I'm hopeful um, that I can do the work justice, right? I'm a person that's still learning, but I'm also a person that's taking what I have in the moment and applying it and then really just working with my folks. So just being really honest about where my opportunities are, where my gaps are, and not trying to fill them by myself, but filling them with our coalition members. One of my coalition members, Dr. Skanes, is doing that work of precepting. Her blood pressure is 180 over 100. And this is in part from her repeating herself into exasperation about her needs to continue her work, right? About her needs to be seen in her work, to be supported. So a lot of the ways in which we're in coalition now is by dire necessity, is not because we're all with these great rainbows of like what's possible, but because we came together and said, hey, let's just put everything we have together because this is quite possibly going to kill you.
Yeah. Yeah. I mean, I think you underscored something that we see as we do these events is that the burnout is real, the stress is real, and it gets hard, and that's why it's important to have some moments of rest, spaces to renew, be connected to people, and so we want to absolutely support that. And you also said something else that resonated with me, that you didn't choose this work, and I'm going to finish your sentence in my way. The work chose you by your experience. And I think a lot of us resonate with that. I know I resonate with that. That's the reason why I do this work, is because of, the life experiences, the things that we went through, the things that we needed that drive us to this work. So as we prepare to take questions for the audience, I want to ask Sonia, what gives you hope at the intersection of where you are? And I know you said you're an insider, but on the outside, I call it being on the edge of the inside. That's what it is. You just barely on the edge of the
Right.
inside because you're grounded in community.
Yeah, I mean, I first of all, just being an invited guest to work alongside my partners on the Navajo Nation, I'm perpetually in awe of like the strength and just, the decades and centuries of community building, the fabric that exists, so that gives me hope. And in particular, like working, I'd say these days with young folks. So we have some programs where we're working with children in middle school, like 6th to 8th graders, who are designing their own campaign, to use Diné or Navajo culture, to promote water, as not just the healthy beverage, but also, a deeply culturally important element of their lives. So that kind of work gives me hope because I think, just being around younger people's energy and learning from them is also, fun and humbling.
Very good. Jenny, how about you? What keeps you hopeful? You said you've been here since '89, and I know you ain't going nowhere. So I know there's
No.
some hope in there somewhere.
I think the midwifery model of care, which is essentially a patient-centered model of care, and the fact that we already know that it works. Like, how much more data do we need? And
Yeah.
at this point, I'm on the evidence-based outrage space as opposed to hope for evidence helping us, right? We
Right.
got plenty evidence. So I think it's building around the person, centering mother, baby, centering family, centering community every single time, every person, every time. And I'm really keen to see us move that same thought process over to the providers, center the providers. Let's hold each other up. Let's be there for each other. Let's be human and humane to each other. And maybe we'll get to what I'm always looking for, which is perinatal power. Let's go.
Yeah. That's fantastic. Perinatal power. Yeah, you had a couple of mic drops there. Evidence-based outrage and
Oh,
perinatal power. I love them both. Okay. So I got some questions. I'm going to start with these first three that came in through the chat. And I have them right here in front of me. And so this one, I'm gonna let it open it up to see who can answer this best or wants to answer this best. Given the maternal deaths that occur in the first 42 days postpartum, how can midwives and doulas help bridge the gap in support during this extended postpartum period, particularly for communities experience the greatest maternal health disparity? So we know that deaths occur in the first 42 days. What can midwives do to bridge that gap? And I think I'm gonna go with you to that one on Jenny.
Yeah, midwives and doulas already do that. We're already there in that space. We are holding it down on our own, unsupported, unrecognized, uncompensated. Let's just throw that out there while we're
Wow.
at it, right? So yeah,
Wow.
midwives can do all the things. What about the rest of us, right?
Yeah.
Like this system of care has no postpartum support whatsoever. And I don't care that we have Medicaid for a whole postpartum year. There's no providers to go ahead and bill for the said Medicaid and hope that they get paid, right? So at the end of the day, midwives simply need to help other folk understand how to do the midwifery model of care. And postpartum care is real easy to do. You talk to the family, you talk to the birthing person, you make sure the baby is thriving. And all people need is some support and answers to their questions. Those mood disorders just dissipate. Nobody's crying. when they have midwifery and doula support in the postpartum period. And it does go on. I think postpartum is for your entire rest of your life. But
Yeah.
that's another story.
Yeah. Well, that's such a powerful answer because and I'm trying not to get emotional when I think about it, because that's what my wife did not have
Hmm.
after our daughter was born. And all of those things that showed up, and we didn't know what to do. We didn't know where to go. There was nowhere to have a conversation and support. So I think you're right. Midwives and doulas are there. The point around compensation, I think, is really important, and support for them to be able to do that work because it is such a critical space and point. Let me get to the second question because I want to make sure we get through some of these. What does each of the panelists think about the evidence, considering that Western academic ways of prioritizing quantitative studies create deficit-based narratives that have a history of being extractive? So, how are you navigating the landscape while shifting power to a community? So, this question seems to be very academic. So, I'm gonna try to break it down in the Anton way. That sometimes we can have plenty of evidence that's focused on quantitative, but it doesn't really speak to the assets that people have, and it usually takes away from communities. So, how do we navigate and shift the power towards communities? Sonia, I'm going to go to you on that because I feel like that's what you do at your intersection of work and on the Navajo Nation.
Yeah, I've been thinking about that a lot. I mean, first of all, like what, kind of like Western researchers consider evidence is like, very, very narrow. There's, there's a wealth of practice-based evidence that goes on for centuries and millennia. So just acknowledging, that um, even talking about what evidence means, I think is something we have to sort of like challenge. I've been really interested in the fact that I have Navajo colleagues who are really interested in research, because
Mhm.
maybe if I were growing up on Navajo Nation, I would be like, why? But these are colleagues of mine that I work with that really believe in research. And we've really tried to look at indigenous methods of evaluation. There are great resources out there now, toolkits, et cetera, so that you're not always trying to like chase some kind of a p-value. We're trying to bring narrative into it, storytelling, intergenerational voices. So for me, it's been, a real privilege to learn about like all of these types of evidence that you can build. Especially knowing again, that just the p-value is not going to actually, translate to change. It's the stories that matter.
Yeah, very good. Really powerful. Um, I'm going to ask this question to you, Janice. The question came into the chat around when it comes to taking action. Where do you all fall when it comes to preparing or getting ready or book learning or just trying to make sure that I know as much as I need to know about evidence and cultural humility and education and implementation, the system history? Like we can get paralysis by analysis just trying to study and learn everything before taking action. So, what point would you advise people to get in the game and stop sitting on the sidelines? How would they go about that?
So they should have gotten the game yesterday, but there's
That's
always
right.
today, right? I think Jenny Joseph said something important when she said, "How much more data do we need?" What data are we validating in ourselves? Like what data are we looking at that we're being told isn't sufficient enough to activate around? How much data, how many reports is it going to take before we implement care as strategy? Care is a strategy. It's not being looked at as one because we live in a white supremacist country, right? So when we talk about how we increase the workforce for midwifery or what that looks like, or someone's questions about midwives improving outcomes, and Jenny Joseph saying they're already doing that, the question should be, how do we get more support to Black birth workers that are already doing that work? How do we have infrastructures of care for the people providing that care? This country is too comfortable with that much labor being laid at Black women's feet and not caring if we've eaten and not caring if we're covering our own rent, not
Mm,
caring if our medical needs are cared for as well. Care in and of itself isn't a strategy. I think the US broadly looks at people's lived circumstances as inconveniences. That's why we have the same of the same, right? We engage people that already have some amount of access, middle class people, folks that have income, but we have conversations about addressing folks that are living in poverty, we don't bring them to any conversations. We don't care about the circumstances. If they actually need their rent paid before they can engage, then we don't engage them. And that's
Mm,
lazy. If
wow.
our work is to bring in community, if it's to advocate for community, if it's to be in and of, then we have to care that someone has not had a meal. We have to care that someone's child needs clothes for school. We need to meet all of those needs before we then say, hey, come learn more. We have to care about people as whole individuals. By and large, a lot of the people we need to bring into this work are going to have a lot to address, and we have to be willing. We need to stop naming those folks when it's time to get a grant or a check or a mic drop. If you're going to name me when it's time to get an award or something, I need the work to be indicative of you wanting me to be seen, heard, and advocated for.
So Jenny and Sonia, I see both y'all head nodding and finger snapping on that. I'm gonna give you a chance to get in on it. Jenny, please go ahead.
These are the conversations that, we yearn for. We want to have these conversations more. And at the same time, these conversations also take their continual toll. This is our weathering. This is the wearing down. This is the blood pressure out of control. This is the all the heaviness, which is why I think if we don't figure out a way as we move forward to incorporate the provider side as well as the
Mm,
community side. Both
mhm.
things seem to need both responses, both solutions. And without the, joint at the same exact time contemporaneously, we will keep doing this hit and miss, hit and miss, hit and miss thing that we've been doing for a long time. So it, like you said earlier, you feel emotion. I feel like I could just cry right now because it's like,
Mhm.
here we are again. And yes, thank God we're here, right?
Yes,
Both and.
yes, yes. Indeed. Sonia, please go ahead.
Yeah, I guess like thinking to like, or maybe speaking to folks who are like within the healthcare system, like myself,
Yeah.
I think like two thoughts that come up in this conversation. One is like, don't stay in your lane. We're so like, we're kind of like just, we're taught and we're literally trained in medical school to like break a human's existence down to organ systems. And
Mhm.
so like, we just have to really unthink a lot of the way that we sort of see humans and come back to a relational form of care. And then the other thing that I often kind of like I was just listening to both of you, Janice and Jenny, as a healthcare provider, like sometimes when I hear folks say, "Oh, we'll use the midwife for this, or we'll use the CHW for that," like it kind of gets under my skin. And so, like a piece of
Mhm.
advice for healthcare providers is to sort of think about like how do we see the folks that are doing the work on the ground that like have like mud on their shoes and have that trust in the community, like they're our eyes and ears, and who are we without eyes and ears. And so to be thinking about like how do we value them and see them as like peers, they like to go to the beginning of the conversation, we really have to sort of flip that pyramid. So like, if you ever hear yourself thinking about how we can, use our community outreach workers for X, Y, and Z, like just even rethink the language that we're using um, as we start to, find ways to build those bridges and create a little bit of equity and value in our community partners.
Yeah. I got one more question that I want to share with y'all from the audience, and I think we're really in the same space of this question, and that is, what's the best way to really engage healthcare staff with the community for actionable movement? Like again, to some degree, you know, you want people to not stay in their lane and color outside the lines, but there might be some fear and trepidation there. There might be some, I don't have a place, I don't deserve a place, or, I don't have the lived experience, right? So Jenny, Janice, what can you say to people who are watching who want to really engage their healthcare partners in a way that brings them and grounds them in community? But there might be some paralysis of those people in healthcare. So what would you tell them to do? How to go about it? How to make it real time and actionable? I'm gonna start with you, Janice.
For me, this is always quite simple because I start any amount of project or day with just reminding myself who I'm responsible, who I'm community accountable to, who am I accountable to, why am I in this work, what values and principles that I claim to have and who am I seeking to serve. And then that, right, if I say these are my values, it has to be obvious within my actions. And we can't not, right? Like how many more bodies have to pile up before we say,
Mhm.
I cannot not. And that's the case for me. And it feels like, sometimes it's just like a choir of screams doing this work, right? And still be asked for yet another report, yet another landscape analysis just feels like violence. What do you have to lose, right? Alabama has the highest maternal mortality in the country. What is there to be lost
Mhm.
from trying, from
Mhm.
advocating? For
Mhm.
me, I'm deeply a person that believes we can create what we need. We have to.
Yeah.
We have to. It's a mandate. And again, this is not accidental. So when we look at it that way, what does that mean? How do we move forward? How do we speak unapologetically? Do we need advocates in the hospitals? And yes, and that just goes back to how do we resource Black birth workers to do what they're already seeking to do?
Yeah. Wow. What would you say, Jenny?
Ditto.
Ditto.
Mhm.
Absolutely. Sonia, anything else to add?
No, I agree. I mean, for folks who are working kind of within the system or on the edges, acknowledging that these systems are put into place, to reinforce positions of power. Well, if you're in a position of power, you're really accountable, So
Mhm.
if Jenny's talking about this sort of like, well, who's going to make the first move? To me, I think the responsibility like falls on our shoulders as healthcare providers or healthcare
Yes.
systems.
Very good. Okay, I got one final question, and this is kind of we all I didn't plan these questions to go in this order to help us to get to this place, but I'm gonna just put it in this way. Let's say we are starting from the ground up. We can start from the very beginning to build a healthcare system. And so I want to hear from each of you. If you were building our healthcare system from the ground up, what are two changes that you would make to ensure that the people themselves are in the driver's seat? And I'm going to start with you, Jenny, then go to you, Sonia, and have Janice close us out.
Absolutely. Don't do anything without having representation on whichever, group, panel, meeting, board, decision making, whatever. Like, do not do that. Otherwise, we're going to repeat the whole sorry mess. As far as for the providers, no matter what the discipline, every provider needs to understand who's in the ecosystem, why they're in the ecosystem, and how the ecosystem impacts their potential clients and patients. When we get both of those things balanced, then we might be able to hold this. It will not become a house of cards. That's my thought.
Fantastic. Sonia, how about you?
Yeah, I think like building on what you're saying, Jenny, um, I think honestly, 70 to 80% of the healthcare could happen in the community, just like sort of flip the entire pyramid. And there's just so much that we can do. And it demonstrates, some humility and reciprocity by designing it that way. And I'm also, I have the fortune to work within a tribal healthcare system, and there's a Self-Determination Act that allows tribes to actually own and operate, their healthcare system. So I kind of wonder, like, what would that look like if communities owned their healthcare systems, And I would just love to see some, kind of moral imagination to really kind of imagine what that would look like.
Very good. Janice, you're on mute.
I do my best work on mute. Healthcare needs to be led by Black birth workers. For me, I think there's a lot of necessary resource and information being lost by ageism within the movement. I have learned so much from sitting under my elders and learning and listening and just being deeply present. I think being deeply present in community in and of itself is a lost art.
Yeah,
Also, just removing mandatory reporting. Policing doesn't belong in systems of care. There's nothing about policing that's inherently based in care. It shouldn't be present.
fantastic. Okay, for our audience, I need you all to do something for me. We're going to take a quick poll. And the poll question is, what conferences are you planning to attend this year in 2026? We want to get some sense of where people are traveling, gathering to do this work, what work they're attending to. And then we have a second question is, we want to know how the intersection is helping you. And so we put a statement there to give you a single choice answer. We want to give you about 60 seconds to answer this poll question for us. It would be really helpful to us to make sure that we continue to build great events that give you the kind of insights and information to support. And we want to be where you are. We want to build the intersection in real time if we can. So the more we learn from you, the better it will help us. So just take a second to take that poll, and I'm gonna wrap us up because I felt the power in this conversation today. So grateful that I got a chance to be a part of it with this phenomenal panel. I want to offer big thank yous to Janice, Jenny, and Sonia for being here today and sharing their insights, and for all of the attendees who are with us for the comments, and the chat has been on fire. I've been watching it, and I'm so glad that you all participated today and gave us tremendous value. To everyone else who's watching, this is what I want you to understand, is that we want you to stay connected to the intersection. And if you're not connected, we want you to get connected. So you can sign up for updates by going to meetattheintersection.org. Please go to that link. Again, please follow our LinkedIn page. Subscribe to our podcast on Apple, Spotify, Amazon, wherever you listen to your podcast. And more importantly, we had a conversation today about burnout and the challenges around it, and that people need some safe space to rest and renew. And we want to invite you to join us at our next event, which will be held on March 25th for Rest and Renewal at the Intersection. This is an opportunity to pause, to reflect, and to restore as we continue the important work of advancing anti-racism, anti-racist practices and policies in our healthcare system. We know that this work is important, and we know that we have to be prepared, capable, and comfortable to keep doing it. And we can't do that if we don't take a beat, take a breath, that we rest and renew ourselves. So join us on our next event on March 25th at the intersection for an opportunity to pause and reflect. Again, my name is Anton Gunn, an advisor to the intersection. I want to thank you all for being here. Everyone, have a fantastic day. We're grateful for you.